Hello, Chris. Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. This afternoon, it's 5 p.m. over here in Cape Town, and I say that because it's 8 a.m. in Los Angeles. And our speaker this evening is somebody that's been asked to come back by popular demand. You'll remember who she is. Sara Nasserzadeh, you'll remember, comes originally from Iran, and then she spent some years in the UK where she worked, and she's been trained, highly trained, has become an author and a person interested in all sorts of things that you're going to be hearing about in a second. Her presentation this afternoon, well, for her in the morning, is Bodies, Borders, and Bliss. And you're going to be hearing lots more about that in a few seconds. She's going to be sharing slides. Just to remind you that her sponsors here are the Pelvic Floor Foundation of South Africa. With me is Professor Steve Jeffrey. He's the co-chair, and my name is Peter de Jong. That's the other co-chair. Next week, just to remind you that we've got Dr. Professor Trudy Smith, and she's speaking about the latest oral contraceptive from Adcock Ingram. So that's next week. So without further waste of time, ladies and gentlemen, just to remind you that in October, Steve, is the FIGO meeting right next door here.
Yeah.
The FIGO Congress.
Can't forget.
Can't forget. Be sure that you're over there. Be sure to make it snooze and lose. So, Sara, Bodies, Borders, and Bliss, we look forward to hearing your presentation, and we'd love you to share your slides. Thank you very much.
Sure. Thank you so much. And I'm really glad to be here with you all. I'm just going to speak a little bit, then share the slides, and we'll take it from there.
Thank you, Sara.
Hello, good evening. Of course, my pleasure. Thank you for having me. Good evening, everyone. I'm assuming everybody is in Cape Town or South Africa but me. So good evening to everyone. I was thinking what to bring to our conversation today, and I thought something concrete that I can share with you is a wheel of context for pleasure, women specific pleasure that I can share with you with the hope that you can walk away with fresh perspective and also maybe some tools that you can use with your patients and clients. And at the end, if we have time, I will be more than happy to stay and answer any questions or we can exchange thoughts as the time allows. So if you allow me to share the...
Chris, would you allow? Thanks, Chris, for being with us this afternoon. There we go.
Yes, and Chris, thank you for organizing everything, actually. So he's the one who got me here.
Well done, Chris.
The reason I titled this presentation, Bodies, Borders, and Bliss, Reframing Women's Pleasure in a Global Context, is because we are all informed by all the information that we receive. So it's not like I was growing up in this piece of town or village or even the country of my own and just influenced by the surroundings that impacted me on a daily basis. And I exchanged information with. We are all connected to social media, to the global sphere. So we are all connected to certain elective informations that we receive on a daily basis. And without even knowing, we evolve in our own understandings around even simple concepts in life like pleasure. By the way, I would like for you to connect with me via my website, the Instagram, anywhere that you can. If you have any thoughts, questions, comments, and you would like more resources, I will introduce more along the way, more ways to connect. So then the conversation today is sexual pleasure, wheel of context. The reason I come up with all of these wheel of context for sexuality education, for pleasure, for everything needs to have a frame for me within which I operate. One of the reasons is I don't want to leave anything to chances. I want to make sure that I cover the bases. I look at all the aspects that might be, at least the majority, not all, but majority of aspects that influence a very specific concept or pain point for my clients and patients. One of the ways that I do that is we review, so with Dr. Azamina, we reviewed all the information that is available from political, economical, financial, medical, all of that information as it relates to pleasure across the world. And pleasure, even the term pleasure, is defined, experienced, and expressed very differently by people around the world, as we get into today. So I want you to keep this wheel in mind. And I know that this webinar is being recorded, so feel free to come back to it and then get pieces out of it for your own work. And feel free to also add and minus, plus, whatever that works within your work setting. So the first piece in that wheel is the personal history of the woman. A woman raised in a household where pleasure is taboo, sexuality is taboo. Even forget about sexuality, just think about pleasure. Pleasure is a taboo. In some of the countries that I work with, pleasure equates to greediness, being animalistic, being less than a human, being less than that sacred, virtuous person. So if a person grows up like that, the blueprint of pleasure that is implanted in them can facilitate or hinder the way that they connect with their own pleasure. So this is something that we need to explore with the people that we work with. So when they come to us, let's say, for example, they say, I have sexual pain. I would like to have more pleasure. If pleasure is in the mix, we always go after how was pleasure discussed in your family of origin? Who was entitled to it, who was not, who was given the pleasure. And many women, for example, specifically to sexual pleasure, think that there is a guy, specifically guy, that has to come and give them pleasure. So there's no accountability or embodiment of the pleasure that they need to produce for themselves in a way. So was it connected to consensual loving relationships, or was it connected to something that is not for you, but for the other person involved? So these are the questions that we ask. Here's a tool that I developed that I would love for you to consider when you're working with people, especially around sexuality. The way that I describe anything that we do is something that has a blueprint, where we are coming from, and then the reality of life that we are experiencing and where we are going with it, the desire, the space. So if you look at it this way, that's why I called my new book Love by Design, because if you are familiar with design, we always have a blueprint. We need to have an initial idea where we are going. Then as we get to work, we see what works, what doesn't work. We revise and revive everything, and then move to the outcome that we want to design for ourselves. So intentionality is a big part of this piece. With the sexual blueprint, these are the questions that I recommend. Did you grow up in a household where your parents showed each other any kind of physical affection in front of you? Or were they more reserved? And it was preserved for behind the closed doors, or you grew up thinking that I have a lot of adult clients in certain cultures that they say, well, it never occurred to me how I came to the world. It never occurred to me that my parents could even be sexual with one another. And if they are sexual with each other, I don't want to know if my parents are sexually connected with each other or not. So these are all points of conversation. Even if you're a medical doctor or a pelvic floor physical therapist or a specialist, these are the conversations that we still can bring. You don't need to necessarily be a psychotherapist or psychologist to get into this, because the body is going to prohibit the person to improve in their healing process. So the more we can get out of them, have them articulate what is happening, bring it to their consciousness, the more we can work with the body and the integration of the body and mind and the progress that they want to make. The second one is, if you were raised within a particular religious tradition, and what values around sexuality, and in this case, pleasure, was communicated to you. Was it positive? Was it negative? Neutral? What were the values? How did your culture view sex and sexuality? What were the messages you received as a child and later in your adulthood about the role and purpose of sexuality? Was it for reproduction? So if sex is only for reproduction, then pleasure is not a part of it. If If, for example, even with food, forget about sex, even with food, if food is utility, if it is scarce, if it's just to nurture you in a sense that, you keep your functionality, you can't really connect with the pleasurable and enjoyable part of it. So these are the ones that we can really bring to the forefront of our clients' and patients' minds. What were you taught about masculinity and femininity and physical attractiveness? This matters a lot because, especially in cultures when we have a lot of gender roles, especially binary gender roles, men and women, and as we know, there is gender fluidity now that we are having a global conversation around. But in certain cultures, when we have only masculine and feminine, and also they can't cross paths. Remember that really famous book that men are from Mars and then women from
Jupiter.
oh
Venus.
Venus, women from Venus and men from Mars. So it's as if we are so separated from one another that any intersection, even a man wanting to try something that is a little bit colorful, they are immediately labeled as, oh, you're a sissy, oh, you're not as masculine. So what were the messages around masculinity and femininity when they were growing up? What were the messages around physical attractiveness? What makes you attractive to whom? All of these come into play when it comes to pleasure, because then the person thinks, if I'm not feminine enough, maybe I don't deserve pleasure in a certain way. Or if I'm not masculine enough, I'm not able to induce pleasure in somebody or have pleasure for myself. So these are the ones that, by the way, that we are talking about women mostly today, but always I think about everybody involved, especially men in patriarchal culture, because they have to perform, they are the utility. They have to bring the performance. So there's a lot of pressure on men as well to bring the pleasure, to be the holder of the pleasure. So these are the things that we need to keep in mind when working with clients to free them up from those structured that thinking that they were put under. Were sex, sexual pleasure, and physical pleasure considered a normal part of life? Or was there a sense of secrecy attached to it? What about shame? Quite a few of my clients that they are completely shut down from their genitals or any kind of pleasure in life, including eating, including anything that in a very primal level can bring us pleasure. They are the ones that carry a lot of shame and guilt around anything that gives them any sense of enjoyment in life. So that piece of it we need to decode and talk about it with the clients. Let's say, for example, somebody says, I can't really have pleasurable sex. Talk to me about other areas in your life that brings you pleasure. That will open a whole different world. For me, sometimes I don't even talk about sex. I talk about food a lot with my clients because food is something that is globally connecting people, and people connect to because our survival depends on it. So you can tackle that. For example, when you eat food, do you have enjoyment? Then you can know that, of course, there are some physiological and psychological reasoning behind not enjoying anything like depression or severe anxiety or different mood disorders. But we're not talking about that now. At even the surface level, we need to see whether they even think that they are deserving of taking pleasure out of anything that they do or connect with in life, including sexual pleasure. Other questions could be, was everyone seen as equally deserving of sexual satisfaction? Or it was preserved for a specific group, for example, married group, men, or people of certain age, people of certain phase of life. What were they? We will talk about that a little bit more. Or people who are of certain body types. Would they enjoy sex more? Should they enjoy sex more? When you became sexually active, not necessarily intercourse, but you started touching yourself, pleasuring yourself, or stimulating yourself, or had any sensations that was sensual for you, was it a cause for celebration for you? Did you enjoy it, or were you scared, or ashamed, or neutral? You didn't really make much of it. What did you call your genitalia when you were growing up? I actually want all of you who are on the call, pause for a second and think about this. Growing up, what did you call your genital? Did it have a name? Did it? One of the research, I don't remember if I spoke with colleagues in this group about that we've done was genital practices around the world. And within that, we ask people from so many different countries that what do you call your genitals? And that has a lot to do with the way you connect with your genitals, the way you express yourself through them, and connect with other people through them. For women, I will show the map of different countries. For women, unfortunately, it's mostly about minimizing and cutifying or related to fertility, the names that they use, or no name whatsoever, as if it doesn't exist. And for men, it's all about utility. It's all about performance, like the pipe, like the dragon, like these sort of things that, come and rescue the day or get somebody pregnant. Or so it's about performance and utility. And put the two together, you will see the mix. Do you know your sexual, gender, and relational orientation? Have you ever reflected on that? Up to this moment, have your genitals been places of shame, pride, liability, confusion, or pleasure? For many women and men, for that matter, liability is a piece there. Don't get pregnant. Don't get diseases. Don't get anybody pregnant. So all of those messages in the back of our head. And then it affects the way that this place, if it's a place of liability, am I going to also get pleasure out of it? So how am I marrying these two? Has this been information that you were comfortable sharing with anyone, including your partner, if you are in a partnered relationship? And especially when they come to us, because you're the expert, so to speak, we can really provide that safe space for people to talk about these issues. But we should really make it in a way that they don't feel like, oh my God, I'm asking this question as the expert, but I feel so uncomfortable myself. So if we want to make them feel comfortable, we need to make sure that we put ourselves out there in the mix in the sense that this is expected. I have this conversation with everyone in my office, so feel free to talk. Nothing can shock me. Everything is okay. I hold this space for you. So your demeanor, your way of approaching these questions matter a lot.
So on that point, Sarah, I just want to know, so obviously you're embarking on quite an extensive amount of history, but in probing into someone's, upbringing, etc. Most of us on this call are clinicians. Admittedly, we're all most of us are gynecologists, but to what extent do you think we would, if you had time and the motivation to try and get to the bottom of things, I found that possibly the patient might find this a little bit uncomfortable probing into all this. I know in terms of your circumstances and your context with which you see your patients, this is all expected, but I'm trying to imagine Peter Young probing all of this with his patients. It might, what do you think it would be quite strange for them? Or I don't know. How do you think we embark on this sort of history? Because I mean, it's obviously very important, but
and one
I'm
of
just
the
not sure how I
impediments,
would go about this with my patients.
one of the impediments, Sarah, we
Yeah.
have is different cultures. For example, we are from a background of Roman Dutch, with the European upbringing and education, and the patients might be indigenous people that do not share our same mores, values, cultures.
Mhm.
So that is something that we have to be sensitive to and sensitive for and sensitive of, is that their backgrounds, education, cultures, religions are all completely different and foreign to us and vice versa.
But then again, maybe it's
Yes.
our own reluctance or our barriers that are preventing us from maybe having these conversations as well. So, we bring our own context into the whole thing, and having this conversation with Sarah is so important. And
That's right.
maybe we're missing out
That's why we have to
a
explore these
wealth
issues.
of therapy or wealth of options in terms of getting these patients to talk to us.
Quite right.
Yeah.
Sarah?
Right. So I'm glad that you brought up this question because one of the things that we need to pay attention to based on research is where is the first point of contact? for people, for women specifically, is the gynecologist.
Yeah.
We all do see gynecologists at some point in life. So sometimes that's the only point of contact that we have with any expert, because we have to give birth, we have to, like all of that, right? It depends on how you present it. So let's say, for example, you're working with a patient, you are examining their genitals, you're looking at the genitals. You can actually talk about the genitals. You say, hey, the basic thing you can say, hey, this is really interesting, actually. There are so many different people who connect with their genitals differently, and they treat it as a very different, no-name part of the body. I want you to know that the way that I look at it is you have nose, you have eyes, and you have genitals. So we can talk about it. And also consider this, because you are male clinicians, of course, people, especially from different cultures, they might not feel more comfortable to open up about most basic things. Let's say, for example, how do you connect with your pleasure? How do you touch yourself? They might not want to share that with you, right? I get that. But on the other side of it, because you have that privilege to look at the genital, you're working with the genital, you can either put that even in your intake form. You can have them fill out the form ahead of time so that they don't have to be face to face with you. And then you look through the form. If they fill it up, then you can say, hey, I noticed that you put this. Many of my clients and many of my patients say this. How about you? So making it about the range of patients rather than that patient specifically to single out. That's one. Regarding the indigenous and other groups of people that you might not even know about, naming their genitals, nicknaming, if you wanted to call your genital, what would you call it? That would be something that gives you a very good idea. If a person calls it no name, shame, I will go through that with you later. Then then you can open up a conversation as you are doing the exam, as you are going through your process. You can incorporate it in the process. So when you call your your vulva shame, how do you think it will open up and it will show up in your sex life? So, little by little, we can do little by little, obviously tailor it to the clients, obviously tailor it to what bring them to us. I have a lot of clients who come to me after they've seen their gynecologist, and they say they are recovering from cancer, for example. They are postpartum, and they say, well, the gynecologist said, this is too soon for you to talk about pleasure. This is too soon for you to talk about your sexuality. They didn't even bring it up. They're waiting for us to bring it up. So let's say, for example, a patient comes after they gave birth, or they come with pain dysfunction or infection or UTI, whatever that they bring them to the GYN office. We can just say, hey, I'm noticing that you've been in pain for quite a while. How is your sex life? But if you keep your face straight, so it will open the door for them that this is a doctor-posed question rather than something that you are actually shying away from it as well. So I didn't intend to cover this part in this conversation for us, but let me also introduce our colleagues to 4 roles that I always teach on. One of the roles is authority. One of the roles is facilitator. One of them is delegator, and one of them is demonstrator. I always teach that across the world, urologists, gynecologists, and anybody really in any field. Authority is when there is huge shame, then it's doctor recommended, doctor proposed. So people follow, I am the one who is going to have the power and confidence for all of us in the room. Facilitator is more of the questioning and helping them get to the understanding, which I understand is out of the medical realm for the most part, because especially with the time limit that you have. And then the other piece of it is the delegator. Sometimes you can actually tell them, hey, there's a book, you can go read it. Here's this video that you might enjoy watching. Here's a group that you might want to connect to. So delegation. And then the other one is demonstrator. You can teach them at least about the anatomy of their body. If you have the models in your room, you can teach them about what foreplay does, for example. If you spend some time cuddling with your husband before, depending on their level of sophistication, cuddling with your husband or with your partner, or for example, if the person needs initiation, has a little bit of a pain, you can actually teach them as how the partner or themselves before the sexual activity can have a little bit of a fingering as a part of the initiation, so that to make the penetration easier for them. These are all the things that we can do if, like the anatomical education, sexuality education, and giving them resources. I believe that this is the minimum we can do, but we can definitely talk about it more. And there's an extensive way that we can really tackle all of those. I don't know if I addressed your comment.
Sorry. Thanks, Sarah. Yeah, you addressed that very, very adequately. Thank you very much.
Of course, lovely. So the next part is sex and gender. In some cultures, expectations of femininity discourages sexual agency. So, for example, you need to be modest. You don't initiate sex with your partner. In some of the cultures that I work with, they don't even take off their clothes to have sex. They just have the parts that are necessary out, and then they have it in the dark. And then there you go. That's it, done. That's okay. But as long as they know what is happening within that space, and it's again pleasurable, the woman is not going to put their body through something that is going to bring them pain time after time, or agony or discomfort. There are stages of life that people talk about when it comes to sexual pleasure, especially for women. Again, men included here as well. Perimenopausal women, postpartum women, as I mentioned, survivors of cancer, limiting their access to support is not a very good place to be. Like the client that I told you that, they say, and this is often, it's not something that is, I see like, oh, once in a blue moon. They come to me and say, well, actually, but my doctor said after a menopause, you should forget about your sex. My doctor said postpartum, no, you can't be really intimate postpartum. Your life changed. This is a new phase. You need to deal with it. So these are the ones that actually limit the access of the patient. If you don't want to deal with it, at least say, good point, I want to address your sexuality as well. You want to be active sexually, so here are the resources for you, or you can go see this person for this if you would like to. So at least have resources. And then differently abledness. A woman with mobility differences, for example, they have disabilities, they have functional pain in the body, they usually don't have the confidence within their own bodies, or they can't really, if they don't know and they don't have the education, they don't know how to be sexual, to have pleasure. So for example, rheumatoid arthritis, some forms of connective tissue disorders, these are the ones that the person is continuously in pain. So we need to make sure that introduce them to different positions that are not going to hurt them. Endometriosis is a good example for GYNs. If they have deep penetration, usually they have pain. So it would be good to educate them, hey, you have endometriosis. While we are watching it, we are not going to treat it or have the surgery yet. I just need you to know that many of my patients who have endometriosis, they report that they have painful sex when they have deep penetration. So here are the other positions that you can have sex with. And then just leave it with them. At least they have the resources. Relationship. If a partner prioritizes performance, or they want to get pregnant, that's the only purpose, or they assume that penetration equals satisfaction and they're not exploring any other routes, if for whatever reason the woman is not able to have penetration, then they look down on them. So let's say the woman doesn't feel comfortable having sex during their period. So is there any other way for them to be intimate or sensual with each other? So we can teach them that the skin is the biggest organ of the body. So you can actually explore. You can't have penetrative sex. You can be body to body. You can sit back to back, breathe together, or touch each other. You can massage each other. So all sorts of things that we can teach people to still keep that physical intimacy. Language and symbolism. In many languages, a slang for female genitals is derogatory and infantilizing. And sometimes the clients come and they don't even know what to call the act of sex, masturbation, foreplay, their genitals, vulva, vagina, penis. They don't really have a vocabulary because the vocabulary they know is the street language, it's the vulgar language. So these are the things that we can help them. And also we can say, you know, between the two of us, we can use this word for this part of the body. No? So there's always the way. And then to teach them. Now, one of the things that I want to highlight here is, especially with the groups that you mentioned earlier, that they don't share the base of culture with us or the language with us. There are simple, I mean, the simplest concepts in life that might be very differently experienced and expressed. Happiness, wellness, joy, death, sex, well-being, romance, rewards, punishments. And the list goes on and on and on to, you know, norms and purpose and success. We think that if we say it, for example, happiness, everybody needs to know what happiness feels like, looks like, is being communicated. But that's not true. I'm pretty sure on the call, we have colleagues who speak different languages. Think about different languages you speak, different contexts and patients that you work with. See how this could be so different. Death could be a celebration in a culture, while it could be doom and gloom in another, right? So we can't really assume when the client says something, if you feel like, this is going to impact our work together, you need to explore it. How do you feel about this? Are there other words that you use around this in your language of origin? And how do they connect with it? So this is the initial map that we put together based on our research, the genital practices around the world. And as you can see, women, the genitals are egg, mouse. Mouse was actually pretty popular because mouse is something that is there, not to be seen, not to be heard, right? Something to be hidden. And almost sneaky. And this one is kitten or pussy, a cockroach, things that are very minimalized and we are even sometimes humiliating, like, you know, just to chuck away. And then for men, it's just the pipes and flutes and dragons and anything to do with performance, as I mentioned. So utility of it is mostly emphasized. Now, culture and religion. In some religious traditions, when we talk about sex, especially for women, it's a duty. So your body is there to bring enjoyment to another person, or your body is there to bring children for another person, or to the world, or to the community. So if the body becomes that place of utility, there's a huge detachment between pleasure and the utility, because you have to keep it functional rather than thinking like, there's also pleasure involved. Some bodily practices to keep the vagina dry, like a vaginal douche, or they want them to smell differently. And I know that there are certain practices specifically to South Africa in different groups that people put herbs, for example, inside the vagina to dry it, to make it, the friction more pleasurable for the partner. These are the ones that we need to know about, we need to ask about. So when it comes to hygiene, how do you wash your genitals? As a gynecologist, you can totally ask that. How do you wash your genital? How do you trim the hair of your genitals? If they do epilation, if they do like waxing, if they do different sorts of practices, they can have ingrown hair, they can have infections, they can have skin reactions and allergies, they can have yeast infections. And so, for example, if they use not a standard vaginal douche, or even the standard ones often enough, they can get recurring bacterial infection. I had clients who came to me with pain disorder. And as I'm taking the history, I don't even see the genital. But as I'm taking the history, I realized that, there's something here. So I started asking about the hygiene. I said, well, you know, how do you wash your genital? What do you wash your genital with? Actually, what do you wash your genital with is better than how do you wash the genital. because then it could be a little bit of a judgment that do you even wash your genital? So what do you wash your genital with? And then they say, well, I do this thing, I dissolve it in water and I sit in it. And I ask them to send me the picture. I go read about it. And what are the ingredients? How does that impact the pH within the vagina and the skin? And then no wonder they have pain, because they have recurring yeast infection and it can't really heal because of the practices they have. So these are the ones that we can't really be ignorant about, because it will impact the way that we serve the patients and clients. So the hygiene, the grooming, the way they treat their genitals, are there any piercing, anything that they do that we need to really know about. Now, by and large, when we are working with patients and clients, we also pay attention to, are they more towards the individualistic social system, their way of thinking, their way of behaving and living. And South Africa is one of those countries that is so diverse, based on my understanding, that there are some clients that are completely, to your point, like completely not only of European origin, but actually live like a European person, very independent and very much into the individualistic way of thinking. It's me at the center, then the family and acquaintances, and then socio-political system. But for the majority of the communities within South Africa or Africa in general is the collective system. So whatever that you are working with a specific patient is going to be influenced and is going to influence the people around them and the community around them. So for us, it's important to know that who else is in the mix. The questions that we could ask is, let's say, for example, they come with pain disorder or STI, whatever that they have. We ask them, who else is impacted by this? And they said, my husband. My mother-in-law said I'm dirty. My, whatever that is. Who else is in the mix that we need to know about? And sometimes I have patients that, the medication even is being controlled by somebody else. So I need to know that, right? Laws and politics. In places where abortion or contraception is restricted, women may fear unintended pregnancies, and that's why they hold back from sex and pleasure. And it will very much inhibit the way that they show up in their sexual life and interactions. And the public health. Many sexual education programs based on abstinence only. So you keep away until you're married, then the gate is open for anything. Omitting conversations on female pleasure altogether. I remember when we first time in England, it was maybe, I think 20 years ago, was the first time that we put the word pleasure, and I was a part of it. We put the word pleasure in sexuality education. And that is stirred the pot a little bit. But then now, 20 years later, it's a part of the conversation. Even when you look at the definition of sexual health and well-being by the World Health Organization and World Association for Sexual Health, the word pleasure is in it. So we are not thinking twice. Since 2002, it's in it. It's in the protocols. The definitions. Economics of pleasure. Lack of financial autonomy for women, specifically in relationships, makes it very difficult for them to ask to be in a pleasurable and equitable relationship. For the most part, they need to serve the relationship to be deserving of that economic reimbursement. So if women don't feel like being sexual with the partner can easily cut them off of the money, of the inheritance, of the everyday living expenses. So for them to be in the mix and to survive a dynamic, they need to use their sexuality, which leaves not much of place for pleasure. And when it comes to products and technologies, it's only recently that we have porn produced for women's pleasure. Very, very minimal. It still is very much geared towards men. And on the other side of it, there are toys, sex toys, there are dildos and vibrators, whatnot, that they are evolving little bit at a time. They're not active still, but we are getting better and better in bringing more tools and more products that are female produced, having the female body in mind and female different varieties of desires from women in mind. Now, one of the things that you will see is the systemic bias in every society reflects the technologies and the products are being produced in this space of sexuality, and especially when it comes to pleasure. If people believe that a woman who pleasures herself is going to be histrionic, is going to be not satisfied within the marital space, is going to be loose and goose, you know, that the terminologies that people use, and is going to be just a bad woman, loose woman, if they ask for pleasure, then these products are going to be very much limited. In certain cultures that I work with, vibrators for women are sold as face massagers so that they can actually import them into the country. Everybody knows what they're used for, but as vibrators for women, but they are these products are being marketed as face massagers so that there's no systemic bias or censorship around them. So we are progressing in one way or the other, sometimes directly, sometimes we go around it, but it's good to be aware of. As gynecologists, it would be very helpful for you to surround yourself with variety and inclusive resources that you can just introduce, like a pamphlet. Just give it to the client. Hey, these are the things you can use. If you don't have the time to discuss, at least you send them off with something to read, to watch, to do. So last but not least, women's access to pleasure is shaped very much by the intersecting systems and the cultures that they live in. I invite you to adopt a holistic lens, assess them holistically, not only by function and dysfunction. Ask about pleasure. When was the last time you had sex that brought you joy? When was the last time you had food that brought you joy? When was the last time? And in the South African culture, food is a big part of life. So we can definitely talk about that if people don't feel comfortable talking about sexual pleasure. A lot of my clients who have issues with sexual pleasure, they have issues with eating. They have control issues. They have anxiety issues. Sometimes it's a manifestation of trauma in their lives. And develop intercultural literacy, avoid assumptions, and ask about their beliefs around pleasure. Normalize pleasure. This part of your body is actually pleasurable. You can pleasure yourself if you like. We are not going to push them against their religions or beliefs, or you can share it with your partner. One of the things I want to also say here is actually, I will put it at the end, and use inclusive language. Mirror your client's language and metaphors. So, for example, if you don't want to name your genital, what would be the metaphor? Some of my clients say a broken glass, a locked door. So these are the ones that help a lot when we are working with people. Now that you're in pain, like gynecologists could easily ask this question. You came to me for this issue. How do you describe it? Oh, I feel like I'm broken, or I feel like I fell off the cliff, or I feel like, the ants are eating away from my genitals. So whatever that they come up with, we can work with. And then support their sense of agency, guide women to define and pursue their own pleasure narratives. I live in the United States now, but thankfully I travel the world. So I see how this is different. I'll give you an example. In the US, there is a lot of pressure on women. And I know that I spend the whole hour talking to you guys as talk about pleasure, but also please don't pressure the woman for pleasure. if they are not complaining about it, if they are satisfied with their sexual life, we don't need to push them and liberate them, so to speak. I have a lot of people who are made to believe that they are broken, and because they are not experiencing orgasm, because they're not having sex dangling from chandeliers, or have earth-shattering pleasure in their lives. We have to really work within the client's expectations, introduce them to certain things, and just leave it to them and follow their guide to their own pleasure. Now, at the end, I would like to introduce two resources. One is the Orgasm Answer Guide that I wrote with my three esteemed colleagues, 80 plus question and answer about orgasms, if you're interested. And the new book that I have, Love by Design, there's a whole chapter on the sexual chemistry and harmony. You can read about the sexual blueprint, touch lexicon, anything that if you're interested. And that's my website, Get in Touch, Instagram, and also The Common Ground is my monthly newsletter that I offer one topic from literacy to fluency and reflection points. I look forward to keeping in touch. Thank you. You're muted. You're muted.
I'm muted. Okay, thanks very much, Sarah. It's wonderful. Can you just go back to that last slide of yours that you Love by Design?
Yes.
I've been looking at your websites and things. It's wonderful. It's a beautifully broad panoply and resource that you do provide over here. Where would you say we should begin? Which book would you say offers us a bird's eye view of the talk that you presented tonight? Would it be the last one that you've mentioned, Love by Design?
Love by Design is the Bible of any kind of relationship. That's what I call it. So because it introduces the 6 key ingredients in any thriving relationship. It could be used in intimate relationship, with children, at work, anything, because it's respect, compassion, all of those ingredients defined differently than many people are familiar with. So that would be it. But specific to sexuality, colleagues can read that Orgasm Answer Guidebook. I think that would be helpful for them.
Place to start. And where do
Yes.
we obtain those books? Are they on Amazon or are they through your website?
They are everywhere. The Love by Design is, yes, in South Africa, actually, you have it too. I have quite a few readers in South Africa by now. I hear from them. It's on audio, Kindle, everywhere. It's actually everywhere. Orgasm Answer Guide was published by Johns Hopkins, so it's only in hard copy, and it is on Amazon as well.
Okay, thanks very much. Steve, would you like to thank Sarah?
My pleasure.
Yeah, thanks. It's been wonderful. You've certainly opened up a very important area that we arguably don't really go into at all. I mean, as doctors, we stick clinical, we stick, almost to the anatomy, and, we won't embark on all this really important part of the history taking. And yet there's a whole world out there that we are probably missing.
Yeah, I think
I think what you've told us today is that, it is part of what we should be doing.
And be comfortable with what we're doing, Steve.
I mean, we have been quite lucky to have a number of talks around sexual relationships on our webinars. And I think, I think we are compelled to embrace our own, reluctance somewhere, and, do things for our patients that we know are good. And I suppose this is where we need to start having these conversations and getting past our own discomfort. Yeah, and
Love by Design.
Going beyond our own borders, which is part of the topic of today. So I think it's important, and because it is difficult sometimes to get patients to see other people. So we are often the best place to embark on these conversations with patients. And I mean, someone like you, Peter, I mean, you've got a lot of patients who've been coming to you for decades, literally. And I think
so what are you saying, Steve?
I'm just saying you're well placed to do that. I know your patients. I see patients who see you, and I think someone like you and a lot of people who have excellent relationships. I mean, some people have delivered like all 3 of her patients' kids and are seeing them for menopause. I think these conversations are best had by these guys. I see there's some other old, not old, but some other guys on the session who are the same, you know, and I think it's something that needs to
Steve,
be
and
had.
another
Yeah.
thing, Sarah, that is actually very fulfilling for us in our practices is seeing women that are not necessarily binary, that are gay women, and also they come, and I guess you can say that they feel comfortable if they bring their gay friends and they bring their partners, and you can expand on that. I mean, it's wonderfully fulfilling to have people from not other cultures but other orientations
Yes.
that are in our practice, and they feel comfortable in our
Yeah.
practices, and I feel comfortable with them.
Mm.
And I mean, if they weren't comfortable, they definitely wouldn't come back, and they wouldn't bring their partners and friends along. So I think that is a confirmation that you are
Yeah.
getting through to them.
Yeah.
Yeah, so that's your sign that you have already provided that safe space for them. You know, one thing that I find helpful for medical professionals, even if you don't want to address it head on, just to put the seed out there in your intake form, you know, when they come, just in the
Yeah.
intake form. Would you like to have conversation around your sex life? Or
Yeah.
something that like in a delicate way. Like in New York, I actually work with quite a few neurologists, and I ask them to add, like, do you feel like your sense of pleasure has been diminished? So it's the end organ, right? The clitoris and the end organs. So they found it very, very helpful. Even if the client, even if they didn't have the knowledge to help them, the neurologist, if the patient just checked that mark, they would just say that would open the door. Oh, I see that you checked this. Would you like a referral? Would you like to talk about that? Just a couple of sentences to get them talking, and then there's so much resource out there. Even if they don't want to go to see somebody else, at least we open their eyes that there is help available, there's information available for you. It really elevates the quality of life that they're living.
Thanks, Sarah. So Steve, would you wrap it up?
Yeah.
Just to remind you, just before Steve wraps up and says thanks, a final thanks to Sarah and Chris, just to remind you that next week, same time, same place, we have another webinar. It's Trudy Smith, and she's talking on this new oral contraceptive. She's a gynecologist from Johannesburg, and she will be speaking on behalf of Adcock Ingram.
Yeah.
So, ladies and gentlemen, Steve has the
Yeah.
final word as always.
Thank you very much, Sarah. It's been wonderful having you. We know it's still
My
quite
pleasure.
Angeles. We know it's taken time to be with us, but it really makes a difference to hear such an open and you know, comprehensive talk about something that we don't really talk about enough as gynecologists, and given us a lot of food for thought. And I hope all of us would go and reflect on how we talk to patients about these things,
Yeah.
and you know, enable us to open up the conversations and help women a bit better, because I think we are quite well placed to have these conversations, and you know, maybe this is something we should be doing more. So thanks very much.
Lovely.
Great
My
talking to you.
pleasure. Thank you for having me.
And
Thank
thanks
you.
so much for your time. All the very best. And
Thank you. To you too.
thanks, Sarah.
Thank you.
Bye-bye.
Of course, my pleasure. Bye, everyone. Bye.